Becky, thank you very much. Welcome everybody who's joining us from the comforts of their own home and wherever you may be. Thank you, Parminder, and everyone at Valley Hospital for inviting me to speak. I've spoken over the last 10 or so years for Valley Hospital on many occasions, never before from my own little study in my house. So it's a little bit different speaking to a monitor than everyone else who's out there, but we'll have a Q&A session at the end. If you type in your questions, I'll try to get through a bunch of them. What I'm going to do today is talk about what's important to me and my practice, which is the orthopedic management of foot and ankle pathology. I'm going to touch upon some of the major hit list of diagnoses and treatments that I handle, but of course there are going to be plenty of diagnoses and the whole category of trauma injuries that I'm not going to be able to cover during the session. Things that we could talk about, of course, during a normal office hour encounter or otherwise. Just a little bit of background about myself, because it sometimes helps to put some of that to the speaker when you attend a lecture. I grew up nearby, right across the border in Rockland County, just a little bit of a stone's throw away. My training and education throughout my career has been in the state of New York. I started in upstate New York in Ithaca, where I went to school at Cornell. And then I continued my education in medical school in the Bronx at Albert Einstein. And then moving across the bridge, I did my orthopedic training and surgical training all at NYU at the Hospital for Joint Diseases. And then my last stop was moving uptown to the Hospital for Special Surgery at Cornell, where I completed my foot and ankle fellowship in 2006. So today, I'm going to give you my perspective on things. And my employment at this point in time is through the Ridgewood Orthopedic Group. I work principally through Valley Hospital. I'm affiliated with several other medical centers, but my principal flagship work is done through Valley, both in the main campus in Ridgewood and in the Lookout Pavilion in Paramus, and soon to be across the street at Valley Hospital's new building in Paramus that you probably know about. My group is a 10 physician specialty group where we're all fellowship trained. We all are subspecialists in that we all handle specific realms of the orthopedic practices. We cover spine, hand, joint replacement, sports, shoulder, the whole gamut of specialties. So we each sub-compartmentalize within orthopedics, and we don't do general orthopedics as a realm, both adult and pediatric. So I see the whole body and the mechanics of walking and the musculoskeletal system through the eyes of the foot and ankle. This graphic sort of sums that up for me, in the sense that I see things from the perspective of orthopedic pathology through problems that begin where the foot hits the ground. There's different types of feet. So when you look at yourself, whether you're walking on the beach or when you're in the shower, different problems and different manifestations of foot and ankle issues can be interpreted through the type of foot you have. There's the normal, kind of regular arch type foot, but in general, a high arch or a flattened arch foot carries specific pathology that we'll talk about during this talk. Believe it or not, 28 different bones that comprise the skeletal system of the foot and ankle. Roughly speaking, we divide them into three sections. There's the hindfoot and the ankle. There's the midfoot, which is very rigid. So if you asked a human being to bend the middle of their foot, of course, they couldn't do so. All the movement through the foot and ankle comes through either the ankle or the last compartment, which is the forefoot and the toes. Any alignment issue or trauma can have consequences in terms of the upstream anatomical structure. So often problems that can be expressed through knee, hip, or back pain can have their origin in an issue with the foot or ankle. So let's talk about some chronic conditions that I treat. We're going to start with the ankle and move our way into other areas. So the ankle itself can be affected by the general condition known as arthritis. Now, arthritis is a common condition. It affects any joint where two bones articulate. Commonly expressed issues are with knee or hip or even shoulder or back arthritis. But of course, in what I do, we're going to talk about ankle arthritis. The most common source of arthritis in the ankle is from a previous injury. So whether it's something that happened earlier in childhood or more recently, when you have damage to the interior of a joint, that can predispose to developing arthritis. Primary osteoarthritis, or arthritis of just non-specific etiology, whether it's genetic or otherwise, happens in about a third of patients who present to me with arthritis. But we also see various other pathologies, such as rheumatoid arthritis, which is a systemic condition. You can see arthritis coming from patients who have gout, other conditions like psoriasis, or even scenarios where you have a previous infection or a neurological condition. So the distribution of arthritis is interesting in the ankle, in that this graphic that you see here is very unique to ankle arthritis, in that if you were to graph out arthritis in, say, the knee or the hip, you would see a much more linear relationship where younger patients seldom have arthritis, but the distribution climbs as you get older. So patients who are on the more elderly side are more inclined to be affected by arthritis in the knee or the hip, whereas the center of this graphic shows that it peaks in patients in their 40s, 50s, and 60s, because it's a condition associated with injuries, which are more common in patients that are younger who have had sporting or other related accidents from more vigorous activity. Just like any other condition with arthritis, the symptoms are very consistent. You can present with general joint pain, stiffness, swelling around the joint itself, and then the manifestations of difficulty with walking or poor balance because of the associated pain. Just like any condition in what we do, the primary focus of treatment in arthritis is non-surgical. So most patients who have arthritis, we can manage their symptoms very effectively without surgery. That involves the basics, restrict their activity, things that bother them like running or jumping, sports. You can use an assistive device like a cane or even a walker. We prescribe braces. We fit braces in the office. We prescribe medications when over-the-counter medications are ineffective, things like acetaminophen, ibuprofen, sometimes prescription medications, obviously not narcotics as a first line, but different categories of medications can be effective. But we also push the realm of injection treatment, principally cortisone, which is inexpensive, effective, and easy to do, and it carries very little downside. But we can also talk about the realm of more alternative type of injections like viscosupplementation, where you may have heard the term gel injections, or Synvisc is one of the brand names we use, and those are not considered on label. For the ankle, they're only FDA approved for the knee, but they can be done for ankle arthritis as well. And then there's the whole general other topic of biologic injections, which is a little bit of a hot topic in orthopedics. But there is a potential role for using objects like platelet injections or stem cell treatment for arthritis solution. But moving along from there, there are times, unfortunately, where arthritis can be crippling and limiting with regards to activity, and then surgery becomes the front line of treatment. Moving from less invasive and less involved to more involved, for very early arthritis, things like bone spurs, we can actually sometimes clean out the joint with things like an arthroscopy procedure, which you're seeing on that small picture over there. Sometimes we're able to do things like a chilectomy, which is a clean out, which is a more involved open procedure where you can remove bone spurs. But then you get into the realm of surgery, where there's really two options. Those would be the procedures known as ankle fusion or ankle replacement. There's no question that in what we consider in our general way of looking at things, the gold standard, which is, what is proven through the literature and science to be the most effective and time-honored tradition, is what we call fusion. Fusion is a procedure in which you instrument across the ankle joint with implants like this rod or screws, and you're rendering the joint stiff, but it is extremely effective in managing pain. It comes with the downside of eliminating whatever motion you have, and that can have the consequence of affecting the way you walk, or even affecting the joints that are up or down from the joint that is fused. But let's be clear about it. This procedure works. It involves a protocol where you're rendered non-weight bearing in a cast for 2 months, but the upside of fusion is you will have less pain if all goes well. Now, what has become much more in vogue now and is quickly catching up in terms of the numbers in the incidence of surgical management of arthritis is ankle replacement. Arthritis of the knee, arthritis of the hip, arthritis of the shoulder, etc. You will have a joint replacement if you have reached the surgical discussion. That has been a long time in the making for ankles, and we're here finally. So it's like having your cake and eating it too. You want to have pain relief, but you also want motion. Motion is preserved in a patient that is a candidate for ankle replacement. This has the benefit of better normalizing your gait, and that has the ability to improve function. The latest data shows that the acceptance and the general effectiveness of ankle replacement is rapidly catching up to those of knees and hips. It does, of course, carry a higher complication rate than knees or hips because it's a more intricate procedure, but it has become an extremely well-established option. There are only a few conditions in which you're a contraindicated patient or one that is not a candidate for ankle replacement. And those that are patients that have a history of prior infection to the ankle. If you're an active smoker or a very poorly controlled diabetic, you carry a very high risk for complications. So we tend to weed those patients out from the discussion about ankle replacement candidacy. And those that may have a significant deformity from a previous injury are typically shied away from that idea. And sometimes you tend to discourage patients who are extremely young from ankle replacement because these are implants made out of metal, cobalt chrome and titanium, and polyethylene, which is plastic, so they will wear out over time. If you're a very young patient, you would require multiple surgeries over the course of your lifetime. There are many FDA-approved implants that are on the market. When I gave this talk for the first time, probably 10 years ago, there were 4. Now I think there's 13 different implants that are FDA approved. And the technology has so dramatically improved with regards to ankle replacement now that we're able to use elements of patient-specific CAT scan guided cutting instruments and navigation. And those are advents that are options for knee and hip replacement. Robotic knees and hips are done, and that's coming soon for ankles as well. So the technology is fantastic. So in terms of total ankle replacement, annually, I looked up the number, there's probably 750,000 hip and knee replacements done in the United States a year. About 25,000 ankle fusions are done. So you can see that the discrepancy is tremendous. Today, there's almost 10,000 ankle replacements a year done, whereas 15 years ago, a study showed that across academic institutions in the United States, there were less than 300. So the popularity, and this is based upon the success rate of ankle replacement surgery, is exploding, and that's because it works. Ankle replacement surgery can be done as an outpatient now, like much of what we do. And honestly, this is driven a lot by insurance companies that don't want to pay for patients to stay overnight. But we can successfully do procedures now, like an ankle replacement, and send patients home. Many patients will stay one overnight, but that's the most that we keep patients now. It's done with a regional anesthesia, basically a nerve block and a light general anesthesia. And it involves a 6-week period of time in which patients are using a knee walker or crutches, but only 3 weeks or so of that is with a cast. The next 3-week time frame, you're already in physical therapy, taking a full shower, getting your leg wet. So physical therapy has become an extremely important element to rapid mobilization after this type of surgery. Survivorship has shown that after a 10-year timeline, more than 90% of the ankles that are implanted are still in patients. So we're doing very well with our clinical outcomes here. The implant that has been most widely used and that I've adopted into my practice is an implant that was made by a company called Wright Medical and was purchased by Stryker Orthopedics, Stryker being one of the larger United States orthopedic implant companies based right in our backyard here in Mahwah. And this system is a patient-specific technique that is based upon CAT scans that we get, individualizing the cutting guides from one patient to the next. It's specific for your ankle. So we've really come a long way with regards to the ability to do this. These are what the x-rays look like. Metal on each side, plastic in between, and a nice neutrally aligned functional ankle. Myself, I've done over 75 ankles at this point in time. Happy to say I do this with colleagues who are fellowship trained in foot and ankle, who are my team. The nursing staff is well versed with the equipment, and it's become, thankfully, a very successful procedure in my practice. Moving along to other parts of the body that are commonly affected by arthritis in the foot and ankle, and that would be the big toe. Hallux rigidus is a condition that I see very frequently. In Latin, it just means arthritis of the big toe. You see it commonly in patients who are athletes or those who work on their feet, waitresses, construction workers, etc. It's felt to be related commonly to repetitive activities, but it's also commonly seen with genetic association. If your mother, father, grandfather have had it, you're likely to get it as well. Now, the features of this, again, just like ankle arthritis, pain, swelling, stiffness, you can feel almost like a cracking or a clicking with activity and difficulty wearing shoes. If you look at this schematic, the normal flexion that you should see in a big toe is about 90 degrees. In a patient who have hallux rigidus, this patient has probably 35, 40 degrees, which makes it hard to push off the ground. Again, non-surgical treatment, you can understand that the theme that we preach is you'd rather not pursue surgery. So patients, we tell them to buy good shoes. Sometimes people are fond of walking around barefoot, wearing slippers, wearing sandals, wearing a flexible pair of Dockside, something that just doesn't support you. Go out and buy a pair of New Balance or Hoka or a very supportive sneaker. That might be all you need. Orthotics, there's a role for introducing a custom or an over-the-counter insert to help stiffen the big toe and prevent activity-related discomfort. But just like in the ankle, we can prescribe medications. You can take over-the-counter medications. We can inject cortisone. Now, surgery is common. Unfortunately, when you've reached that point where the Tylenol is not working, we can address the problem surgically. The least involved of which is for early stages of this condition. We characterize this as stage 1 or 2 disease. And you can see in that little cartoon graphic that the dorsal aspect or the top part of the joint grows these spiky bone spurs that impinge or bang into each other. A chylectomy is a procedure in which you really reduce the contact by eliminating the top of the joint, removing the bone spurs, rapid recovery. Same day procedure, it's done often with local and just a little bit of anesthesia, full weight bearing, rapid return to activity and physical therapy. And, for earlier arthritis conditions, this is a very pleasant procedure because you can have a fast return to activity. Just like in the ankle, the gold standard for advanced arthritis of the big toe, stage 3 and 4, is fusion. This picture on the right, for those who like the gory pictures, you may appreciate that. For those who don't, sorry. But this is the interior of an end stage arthritis big toe joint. This is not at all dissimilar to what an end-stage arthritis hip or a knee joint looks like when you expose it during surgery. There's no cartilage left. Cartilage is the smooth, pearly white surface that two surfaces of a joint articulate, and you can see that this is all chewed up and cratered, and this is why it's painful to move. Fusion works, and I push that on patients who are looking for a one-stop shop, kind of definitive surgery that carries a very predictable and excellent result. Again, outpatient, it requires a 4-week period of time in which you're committed to a cast and a knee scooter. But after about a month, you're in a boot. I have patients in sneakers within 2 months, and then back to the tennis court, pickleball court, whatever the case may be, within 4 months of surgery. Some patients don't like that. Some patients don't like the idea. They want to wear a pair of heels where it's 2 or 3 or 4 inches. And with arthritis, that's a tough sell, but joint replacement is the alternative to fusion. And while there is a role and a momentum in the ankle for replacement, it is not the case for the toe. There have been many implants that have come and gone, failed, and have had to be revised. If you look at the picture on the bottom, that was a very popular implant called Cartiva, which is a small silicone peg that was placed into the big toe, easy to do. Failure rate was extremely high. So we're still searching for that nirvana, the perfect implant for the big toe. What we do all sometimes do, and you can see in the picture above, is what's called a biological resurfacing or a capsular interposition. This picture highlights the incorporation of a tissue graft. This tissue graft is made out of pig skin, actually. And if you're familiar with valve replacement surgery in the heart, that tissue often comes from a pig or a cow. So we can incorporate this type of tissue into the toe. It's good enough for the heart. It's probably good enough for the foot, right? So that we can resurface and put a smooth surface over the joint. And that sometimes allows us to preserve motion at the expense of needing to do something like a fusion. Moving on to a topic that's very common and of a high volume of the patients that come through my office ask about their bunions. In Latin, the term bunion means turnip. It is often felt to be a growth off of the medial side or the instep of the foot, but really what it is it is an angulation, a deviation of the metatarsal bones in which the toe starts to push inward and it reflects a wider forefoot, so it's harder to fit into shoes. Most patients who have bunions, 3 out of 4, have them on both sides and have a very strong predisposition from their family members. This is what a bunion x-ray looks like. It's a wide foot. Most patients who have this present with pain, and it's right there. It's right on the big toe. It's obvious. They have trouble fitting into closed-toe shoes, and it's hard to wear a nice dressy shoe. It's hard to exercise sometimes when you have friction in a narrow toe box. The problem here is that as the bunion progresses, you can get pain here. It starts to transfer to the second toe. Then you can get hammer toes. So as much as you try to preach conservative care, when you have that bad luck of your genetics or just the situation where your career or your activity level prohibits you from wearing shoes comfortably, you may have to intervene. Even celebrities get bunions. So paparazzi will take pictures of anyone. Apparently, both Oprah and Paris Hilton have bunions, and that's everyone's knowledge at this. It's public knowledge at this point in time. So it's not just a disease for the common people. What we're looking at on the top is the earlier stages of a exclusive bunion deformity. What you want to prevent is the later stages in which you have progression of the deformity, and that leads to secondary issues with the lesser toes, in this case, a hammer toe, and what we call a crossover toe. Not easy to fit into a shoe when you have this situation. Now, to gloss over bunion solutions, if you Google that term, you'll see a whole host of voodoo type options, meaning that there's almost a million different things that you can buy or articles you can read about ways to manage, with yoga toes or spacers or braces or speaking nicely to your foot. unfortunately, nothing works. Whether it's $1 or $1,000 you spend, there isn't a clinically proven solution for halting or reversing the progression of a bunion deformity. I tell patients, your job is to talk me into surgery. I'm going to try to talk you out of surgery. If you wear a narrow shoe, wear a wider shoe. Stretch your shoes. Wear a spacer between the toes. Try a brace. Maybe even try an orthotic. But the truth is, surgery is your last resort. Now, those that do want or in fact need surgery, it works. It does. It's a big commitment, though. I tell patients this is not, a rapid turnaround. You're not going to be, wearing your Gucci high-heeled shoes in 3 weeks after your bunion surgery. You better be in for the long haul. Your foot swells. You will have a scar. It might be stiff and it might hurt, but it's worth doing when you've exhausted all the other options. You have to cut the bone. Back in the day, we were able to, surgeons would counsel patients upon the utility of what we would call a bump and run or a simple bump removal. It doesn't work. The bunion continues to deviate because, again, it's not a growth, it's an angulation of the bone. So we actually have to cut and put in hardware for each bunion surgery to be done successfully. An osteotomy, this is the term for bone correction through angular correction of the deformity and instrumenting with hardware. There are over 120 different osteotomies described for fixing bunions. So this is where it's important to at least discuss or even consider another opinion between surgeons, because you don't walk in with a bunion and end up with a cookie cutter surgery. It is a very important decision based upon measurements that we make, age, patient profile, et cetera. Now, what's happening in the world is that pharmaceutical companies and implant companies market directly to patients. You may have seen commercials for where to have and who and what implant your knee replacement should be done. Now it's here for bunions. So you may watch the evening news and see a commercial for Lapiplasty or something else that is directly marketing to patients. And that's okay, as long as your surgeon tells you that maybe that's not the best option for you. So minimally invasive is a catchphrase. It is a technique that has merit. It is a surgical treatment algorithm that I do participate in my practice. But my word of advice to any patients that comes to me telling me what surgery they want for their foot, I say to them, why don't we handle this like a scientist would and measure things out and discuss what's best for you and not what commercial looks best for you. So there are the summary and the headline here is that there is a tremendous improvement in the technology, the pain management, and the ability to get patients moving with a more predictable correction, but it is not a salesmanship situation. I tell patients, I'm going to offer you the best surgery for your outcome, not the best one necessarily for your scar or what your neighbor had. We template. These are measurements that we make. We grade them on severity, and we again cater the recommendation to the specific patient. But we're doing much better with pain management in particular. I have patients come to me on a regular basis saying, I hear horror stories about pain after surgery. We use long-acting Novocaine type products now that have been used with what we call polymodal, non-narcotic algorithms for managing pain. Patients start taking pain medication over the counter before surgery and on a regular schedule after surgery. It's very uncommon for me to refill any pain prescription that I provide for patients, which in the past, as recently as 4, 5, 6 years ago, before there was really a great understanding of the problems and hazards with the opioid situation that we've all unfortunately heard about in this country, we have completely reversed the trend on that. So it's not something that should dissuade you from considering foot surgery, in particular bunion surgery. But we have patients up and moving quickly. physical therapy within a few weeks, and back in the gym doing the bike or the elliptical machine within a few months. Moving along in the forefoot, a common condition that we see is a pinched nerve. And this pinched nerve is characterized as what we call a neuroma or a Morton's neuroma. Patients with a pinched nerve in the foot will present with pain, usually in the ball of the foot. This is caused by repetitive trauma to the foot. This is a common situation we see in runners and in people who work on their feet. The nerve gets traumatized between the metatarsals and it causes pain, tingling, numbness, in a particular distribution in the ball of the foot. There's two spots you can get a neuroma: between toes 3 and 4, and between toes 2 and 3. Sometimes patients say, it feels like my sock is bunched up in my shoe, or there's numbness and tingling in the foot. That's likely a neuroma. Neuroma treatment is highly effective in the context of managing this problem without surgery. First problem, if you're wearing heels to work, don't wear them, because a narrow toe box compresses the foot, and therefore the nerve is repetitively injured from just normal walking. We can suggest things like orthotics or pads to offload the specific nerve that's aggravated. The hallmark of treatment is a series of 1 to 3 cortisone injections, and that will often completely eradicate what would be an early nerve inflammation. If a patient comes to me, they've had numbness and tingling for 4 years, I'm not sure the cortisone at that point is going to manage the problem. But then again, that's how we tend to start with the treatment. But those patients that don't effectively resolve the issue, we have to take the nerve out. So a chronic neuroma is removed surgically. The schematic down there, the picture shows what a neuroma looks like when you remove it. The normal width of the nerve, what's called the interdigital nerve, is about the width of a strand of spaghetti. In this case, it's thickened and aggravated and inflamed 4 to 5 times the diameter of what it normally should look like. A neuroma surgery is easy to do. It's done with a little bit of anesthesia, and it's a quick turnaround, but again, last resort surgery to remove the pinched nerve. Moving along to another topic of very high volume through my office is a condition called adult acquired flat foot deformity. The tendon that is responsible for maintaining the arch of your foot, which is an extremely important tendon, is called the posterior tibial tendon. Many people have flat feet. I have flat feet. The function of this tendon is to maintain the instep or the arch of your foot and to invert or move the toe inward. Patients who have pain in that arch with a flat foot almost definitely have a problem with this tendon. If you look at a foot like this, there's no arch. If you look at the pattern of how someone walks on the beach or steps onto a weight-bearing sort of machine, which you can have at your disposal at your local CVS or Walgreens, where they have these machines, you can see that there's a pattern of weight-bearing distribution that's uneven. So the foot pronates or falls inward. These patients who come to see me with this issue will typically say something like, my feet get tired, I have pain in my arch, I have swelling on the inside of my ankle when I stand, and I've always had flat feet, or my grandma had flat feet, and I have flat feet too. It's a seemingly benign condition, but not so much, in the sense that if you have this issue and the mechanics progress, it can be a big problem. This is what a foot looks like from the back with a fallen arch. We call this very simply a too many toes sign. If you look at someone from the back, you shouldn't see the lateral 3 toes of their foot. You should kind of see no toes or 1 toe. The problem with this issue is that over time, as the arch collapses, the mechanics of the foot fall apart. It can cause your whole leg to tilt inward. And you've seen patients maybe who have their knees are knocked together. They're the reverse of what a bow-legged knee would look like. It's often because the entire mechanical axis of the leg has fallen inward. An MRI of the ankle with a condition like this will show that the tendon, the posterior tibial tendon, where the arrow is pointed to, is extremely inflamed and often torn. And that's why the ankle looks inflated and boggy and very swollen. The first line of treatment is to diagnose the problem correctly, and then it's to support the arch, build up the arch, lift the arch so that it takes slack off of the posterior tibial tendon. Catching that at the right phase is critical, because the more you walk on a fallen arch without support, the more the tendon stretches much the way an old rope would. So we can support the arch, and you'd have to wear this in your sneaker, or, there are even custom orthotics that are made for dressier shoes. But when you reach the point where the arch is collapsed and the tendon is badly diseased, we often have to prescribe a more rigid brace, which is what you can see on the bottom right, which is what's called a Ritchie brace, or even a custom brace called an Arizona brace. When the bracing and the orthotics fail, unfortunately, yes, surgery becomes an option. This is a big deal. This procedure, which is called a flat foot reconstruction, is involved. It entails a reconstructive effort to realign the bone, repair the tendons and ligaments that are damaged, and it's a major, major commitment. But it's also an investment, because if you're in your 40s, 50s, even 60s, and you have a condition that is pre-arthritic, the goal of a reconstruction like this is not only to manage your pain, but it's to prevent progression, because arthritis is the unfortunate outcome of a neglected flat foot that is symptomatic. And you can see the before and after picture where you want to realign the foot to correct the tilt of the ankle and the fallen arch. It's a scary looking picture because there's a lot of hardware in there, but this is a general construct that we would have to impart for a patient that ends up needing surgery, as a bony correction with a full out reconstruction. But again, we're doing this in the effort to prevent what we talked about in the ankle and the toe, which is a fusion surgery. When it works well. So what you want to get is the infrastructure of the foot. You need to rebuild it, and the result is often very good. But again, we're preaching surgery as a last option, but we're also preaching that benign neglect is not the best decision either. Moving on to the most important tendon in the ankle, this is the Achilles tendon. So the Achilles tendon is responsible for when you step down on the accelerator or the brake pedal of the car. It's when you walk up a flight of stairs and push from one step to the other. The two muscles that power this movement are called the gastroc and the soleus. They're responsible for plantar flexion of the foot. Patients who have tendonitis fall into two major categories. One is calcified insertional tendonitis. This picture shows a huge bone spur where the Achilles tendon attaches to the heel bone. These patients who get this problem tend to be on the older side, and they're chronic, long-standing overuse issues. Those who have non-insertional or higher up in the tendon itself, they're often acute injuries, like if you're watching TV and you see someone, unfortunately, in a sporting event tear their Achilles, or have a repetitive scenario like running or cycling. You can have a non-insertional higher up type of Achilles tendonitis. The layman's term for this bump that's in the back of the ankle is often called a pump bump or a Haglund's deformity. Patients who have this often have difficulty wearing closed back shoes, because if your anatomy is such that you're born with this predisposition to getting this pump bump in the back, that you can imagine that the bump itself compresses the tendon between the back of the shoe, and it's abrasive. It creates friction between the shoe, the tendon, and the bone. Also, strangely enough, to put on your radar screen, there is an association with a specific type of an antibiotic called a quinolone with an Achilles tendon pathology. If you've ever been prescribed Levaquin for a UTI or a respiratory infection, you do have to be aware that if you develop sudden pain in the Achilles area, that it's very important that you stop that antibiotic, and that would be with Cipro or Levaquin, which are well known for reasons that are unclear to potentially cause problems with the Achilles. So that's something to be aware of. But again, we're going to try to treat the Achilles issues gently. You need to rest. If you're a walker and you have Achilles tendon problems, you're not going to be walking for a few weeks. You lift up the heel mechanically. If you take the slack off of the Achilles, you'll typically offload the tendon and it will help to resolve the problem faster. I liberally prescribe physical therapy for the modalities of massage and ultrasound and stim. And those who are very aggressive athletes, I have them cross-trained. So if you're inclined to walk or run, I will tell you you're much better off swimming or doing a bike than you are weight bearing and pushing off the ground. And in extreme cases, I'll immobilize patients. I'll even cast or put them in a boot because that shuts down the plantar flexion mechanism more aggressively. But here's the consequence of untreated, neglected tendonitis of the Achilles. And you see this in athletes, right? Because you pay an athlete how many $1 million to get on the field and his Achilles hurts, you're not going to tell him to sit in a boot and not play for 8 weeks. You're going to probably push him back too soon. These are some local prominent athletes who have had Achilles tendon ruptures that started with Achilles tendonitis. Most recently, on the New York Giants, Sterling Shepard, who tore his Achilles on the field this season. So obviously that's the worst case scenario, but that's why we shut things down before they get into the realm of an Achilles rupture. So lastly, sometimes surgery. So in the variety of the calcified tendonitis, often surgery is necessary because what happens is that the bone spur eats into the tendon, and a procedure like this where you actually go in and remove the bump and then anchor the tendon back down to the bone, it's a highly successful surgery. But again, sometimes when you've exhausted the realm of conservative treatment, if you have a bone spur rubbing on the tendon, there's no therapist or medication on earth that's going to resolve that without surgery. So that is in our armamentarium for options when all else fails. This is what we're looking to avoid. This is what an Achilles rupture looks like. I know it's a little graphic, but when you tear this structure in a chronic setting, it looks almost like the description we use is often like the ends of a mop or a horsetail because the tendon is badly damaged from years of chronic overuse. This is how we repair it. There's 2 ways to repair ruptures. The chronic ruptures that we see are often done with a procedure on the left where we simply sew it together. So we go in and you repair it. Technology has evolved such that we'll often or sometimes use, particularly in younger patients and in those who are athletic, or even those who are less healthy, those who smoke or have diabetes. If you tear your Achilles tendon, you sometimes want to minimize the length of the incision. So this is what's called a percutaneous or a minimally invasive Achilles tendon repair technique. So technology certainly is also associated with different options for soft tissue repair, not just bone reconstruction. Athletes get this problem. You probably know someone or seen on TV. This unfortunately was Kobe Bryant, Kevin Durant, famous athletes. They're not immune to injuries like this. Achilles tendon repair, which is a common problem that I treat in the office, it's evolved such that it's a very predictable outcome and timeline to recovery. And most patients get back to 95 to 100% of their activity after surgery, ultimately. Lastly, we're going to conclude with, I guess, one of the problems, which is the bane of my existence in treatment and in your case as patients sometimes, is heel pain, because it's common and it's a nuisance and it's not quick in terms of the ability to have it turn around and revert back to normal. That is plantar fasciitis. The plantar fascia is an enormously broad, long ligament. It spans the entirety of the sole of the foot from the heel all the way to the ball of the foot. Patients with this problem have pain anywhere from the heel itself radiating into the arch of the foot. The hallmark of this condition is pain in the morning, getting out of bed, but you see it with repetitive activities. I see a lot of it this time of year in the marathon trainers who are pounding 26 miles into their feet when they're used to either not running or running 2-3 miles, and now they've training for their bucket list race. We see it in patients, just those who sit all day and they get up and their heels hurt because you need to stretch and you need to be active. to prevent this condition. But those who occupationally work on hard surfaces, you see this problem very, very frequently as well. In the chicken versus the egg argument, patients with plantar fasciitis upon x-ray in the office often have a heel spur. In the case where you're not sure which came first, the chicken or the egg, here we are. The heel spur did not come first. It's the plantar fascia problem that came first, and the heel spur is a visual that the condition has been chronic, and the spur itself is not the problem, but the inflammation to the ligament is. PT, and more PT. So patients who have plantar fasciitis and who have not improved with heel pads and ice and stretching and Tylenol and Advil, they do well with physical therapy. You need direct manipulation, stim, massage, temperature modalities, ultrasound. It works. It's annoying. You have to spend time. You have to spend a copay. You have to commit to it, but it's worth it, because if you have chronic heel pain, you're not a happy camper. Night splints work too. It's hard to sleep, but if you wear a device that keeps your ankle cocked upwards, it prevents that dreadful morning symptom of heel pain that you get first thing in the morning. We inject sometimes with cortisone. We do sometimes inject with platelets or other biological entities when all else fails, but you're in it for the long haul. If you have plantar fasciitis and you haven't gotten better on your own and you're in the doctor's office, you're probably ready for the full court press of therapy and injections and patients and more patients. Lastly, surgery. Yes, we do like to do surgery as surgeons, but I don't do a lot of this surgery because I always tell patients that if you need surgery, I consider this as a failure for both of us, because though the surgery has a high success rate, it's very uncommon to need surgery for plantar fascia. I probably don't do more than 5 or 6 of these a year. And they're done typically endoscopically with a tiny camera where we can visualize in the picture down below through a camera the ligament itself. And instead of making an incision and cutting it, as you are seeing on the left, we can do it through visualization with the camera. So I'd like to thank everyone for sticking out the talk.